Time for some clinical peanuts.
For discussion, my topic for discussion is how to plan for multifocal IOLs, for the first multifocal IOL. I think someone is marking the screen. Not sure. Okay. Sorry, okay. So the first thing that we need to do before we plan our IOL is talk to the patient. So we have to get to know our patients first and foremost. We need to ask them about their occupation, nature of work, or their hobbies when we plan the IOL for the patient. So we need to find out what their expectations are for the vision after cataract surgery, whether they expect to have spectacle independence or whether they're more comfortable with having reading glasses. Also, when we speak about their occupation or their nature of work, or even their hobbies if they're retired professionals, we need to ask them about what it consists of and what are their priorities. Like some people do like to have night driving as one of the tasks that they really enjoy doing. Or they might have fine work like artistry or certain fine arts and crafts, which requires a higher level of contrast sensitivity. For all these patients, we need to inform them of the trade-offs for multifocal IOLs. Then there are some patients who do not care about these things, but care about being spectacle independent, that they want to have clear vision for distance, intermediate, or near, but they do not really care too much about contrast sensitivity or the issues of glare and halos if it comes to night driving. So that is why it is really, really important for us to get to know our patients before we even start the counseling process for IOLs in a cataract surgery. So yeah. So we need to find out their expectations, whether they expect to have spectacle independence or whether they actually expect to continue using spectacles. A lot of you might have seen that some patients are happier having their frames on because they like the look of it, or they are more used to having glasses because they have had a refractive error since childhood. So this is something that we need to find out first and foremost. Next, when we are giving the option of glass independence, we need to take into account certain important things. One is toric intraocular lenses for correction of astigmatism. Usually when we are giving premium IOLs, such as multifocals or EDOFs to patients, they expect a certain level of clarity. This includes correction of astigmatism. So we do have to counsel them regarding toric intraocular lenses and assess for this as well. Next comes extended depth of focus lenses for distance and intermediate. So some patients are okay with using reading glasses, but they are not okay with having blurred vision for intermediate, meaning they are comfortable reading from their laptops or from their iPads, which is usually at an arm's distance. So that is when we can counsel for extended depth of focus lenses. So multifocal IOLs, we know, correct for both distance and near. Trifocal lenses give excellent vision for distance, intermediate, and near. So we need to make that distinction between multifocal lenses and trifocal lenses. Addressing the patient's concerns is something that is really important. They will ask a gamut of these questions for us. Will I have to wear glasses for distance vision? Would I be able to drive at night? Will I have glare or discomfort? Is it reversible? What are the pros and cons of each of these IOLs? And sometimes if they themselves do not ask this to us, we need to address it so that we manage their expectations as well after the surgery. With spectacle independence, see, there's a surge of refractive laser vision correction these days. There's an increase in post-refractive cataract patients as well who come for spectacle independence. These are the kind of patients that we are more likely to get as young ophthalmologists. So they come with this ability to see without glasses for a really long time, and they want to maintain this as well. So they ask for lenses that provide them with good quality of vision for distance, intermediate, and near, and being spectacle independent. So the type of IOLs that we choose and we decides the quality of vision for the rest of their life. So we need to manage their expectations and give them all the information regarding any particular IOL. So one thing that is really important is to customize the IOL based on the patient's need. Sometimes we might need to mix and match. So a patient might have undergone cataract surgery previously, where they must have been a monofocal IOL that has been put in one eye. They realize that it's not something that they like, and they come to you with the other eye, requesting for spectacle independence. In this case, if you put a multifocal IOL, they will grossly see the difference in the contrast sensitivity. They will tell you that the eye with a monofocal IOL has better contrast than the eye without. So it is very, very important to counsel these patients regarding putting multifocal in one eye, whereas, monofocal. We can do to provide these patients with spectacle independence. It's better to do like a mini monovision rather than put a multifocal in one eye and have a monofocal in the other eye. So we also need to give them some level of continuous range of vision if that is something that they do desire. So that's what I mentioned by putting lenses that provide them with a little bit of monovision. So what are our tools for assessing these patients? These are our tools, these are our toolbox, which is very important for premium IOLs. A good slit lamp evaluation is extremely important. Certain patients might have certain contraindications for premium IOLs, patients with pseudo exfoliation and gross zonular dehiscence, pupillary abnormalities, even a retina evaluation with an IDO or an 90D or 70/80 is really important, because if they have scarring in their retina or various other retinal pathologies, that can affect the quality of vision even when we place a multifocal IOL. Then we assess the patient's IOL power, preferably with optical biometers, because they provide a really good refractive outcome for us, especially with certain biometers that have inbuilt formulae system like the IOL Master 700 other abnormalities in the topography who are not suitable for multifocal IOLs. We also have aberrometers, which help us assess the total internal abrasions, the abrasions that are being contributed to by the cornea versus the internal aberrations. So this also helps us in assessing the type of IOL that we put in these patients. There are certain clear contraindications, as I already mentioned, patients with endothelial dystrophies or various other corneal dystrophies that do require keratoplasty, patients with potential capsular bag instabilities, pseudoexfoliation syndrome, even trauma-induced zonular dehiscence can be certain contraindications for these type of premium IOLs. So now I've spoken a little bit about how to grossly assess these patients from, taking their history, counseling them, understanding their needs to their evaluation. So let us talk about the IOLs itself, because as the primary caretakers and the surgeons for these patients who have come to us, we will have to counsel them regarding the IOLs. So it's important to know about these IOLs a little. So we all know vision in monofocal IOLs is great for distance, but it is blurry for intermediate and near, as we can see here. So this is the difference between monofocal and multifocal IOLs. In monofocal, it is very sharp and clear for distance, but as we come closer, the vision dips. In multifocal IOLs, the distance is relatively clear, the near is very clear, but the intermediate is not too good. And this is why it happens. In monofocal lenses, there is a distinct single focus, whereas in multifocal lenses, there are two distinct foci, one for distance, one for near. So the light that is coming into the eye gets split into these two distinct foci. And how does this occur? Usually these are IOLs which incorporate diffractive principles. So the optical principle of these diffractive steps is such that the step width determines the addition power. So that can be anywhere from, like, say, plus 3.25 plus 3 plus 2.5. That depends on the manufacturing of the IOL. So something about these diffractive steps, you might have all seen those diffractive rings, and that is what I'm referring to as diffractive steps. The narrower the step, the higher the addition power. So the wider the step, the smaller the addition power. So narrower steps are there for higher adds like plus 3.25, and wider steps are there for lower adds like plus 2.5 and lower. Then come diffractive steps based. So as you can see in this image, the width of the diffractive steps governs the addition. As it gets wider, lower is the add. Next comes the height of these diffractive steps. So the step height determines the energy repartition or energy distribution between far and near vision. So higher the steps, the higher the quality of vision for near, and smaller the steps or shorter the steps, the higher the quality of vision for far. As you can see here, the highest the step is, the more energy gets allocated for near vision. And the lower this step is, the more energy is allocated for the far vision, which is the central point. Next, you must have heard of apodization. So what is apodization in multifocal IOLs? This apodization is nothing but redistribution of energy to different foci for different pupillary diameters. So this takes into account your near reflex, where when you're looking for near, there is a little bit of meiosis, whereas when you're looking at intermediate or far, the pupil dilates a little. So what they have done is, realizing this, they have increased the height for the rings that are closer to the center. And as it moves in the periphery, the height reduces as well as the width increases. So as the width increases, distance is better, and energy redistribution for distance is better. So when you're looking at a far object, when your pupil size is slightly bigger, it works better for distance. When you're looking at something near, when your pupil size is smaller, the rings in the center work better for that. So this is basically what an apodized multifocal IOL means. Variable step height from the center to the periphery. So decreasing the step height from the center to the periphery leads to variation of the far and near proportion. And that's why pupillary diameter matters. So now multifocal IOL vision, this is just a simulation of it, where I told you there's 2 points of focus, one for distance, one for near. So the first generation multifocal IOLs came out with clear vision for distance and clear for near. But something that patients really had a problem with was the blurry intermediate. So that is, as you can see here, the steering wheel and the console. And a lot of people, especially in this day and age, use their intermediate vision for their basic day-to-day and their work, such as their laptop and their iPad. So next, we realize there's a need for this intermediate add to the multifocal at around plus 2.5 range. So there are various intermediate multifocals which provide this range as well. But one of the pros for this is it provides a crisp distance vision, provides a better intermediate vision, and reduces the chance of halos. But some of the cons are, in these kind of multifocals, since there is a good distance and intermediate, the near might have a little bit of compromise based on light distribution. So they might have to use reading glasses, or they might need slightly more bright light during reading, and we should be careful of smaller pupils. So this is how it all works. First was the multifocal, or rather bifocal IOLs. Again, this is where we have to make the distinction between what is multifocal, what is trifocal, what is quadrifocal, these kind of things. So first to come into the market was multifocal, but rather they are bifocal IOLs, which provide good distance vision and good near vision. So the near vision that is provided is around 40 centimeters. Next came the first generation of trifocal lenses, which provided good distance, then good near at 40, and the intermediate was around 80 centimeters. Next came quadrifocal. Why did this quadrifocal come in? Because we realized that most of these patients, in fact, had a intermediate range of around 60 centimeters and not exactly 80 centimeters. So that's when these quadrifocal this quadrifocal technology came into the market, which was providing a good distance, then one more step of intermediate at around 120 centimeters, another step of intermediate at around 80 centimeters or so, or 80 or 60, and then 40 centimeters. Next came the trifocal IOLs, or the next generation trifocal IOLs, again, which I mentioned was at around 60 centimeters intermediate. So the 120 and the 80 centimeters was okay for patients, but they'd rather prefer as 60 centimeters. So this is where there was it uses the quadrifocal technology itself, but it redirects the 120 centimeters intermediate step height to the distance that provides 3 focal points, which is intermediate at 60 centimeters and near at 40 centimeters. So this is a little bit of a review of certain diffractive technologies that are available to us. First generation multifocal IOLs, like I said, simple distance focal point and one add power for a near focal point. Next, traditional trifocals, which is 2 step heights, that is 2 add powers or 2 focal points, that is 80 and 40. Next comes the trifocal, which is again distance 80 and then 40. In this trifocal technology, majority of the light distribution was happening for distance, which means that distance was quite crisp. But at the intermediate and the near, it was even light distribution, max to distance, but the rest of it was distributed amongst intermediate and near. Now, quadrifocal technology used light redistribution such that it was same for distance 120, 60, and 40. So at all these 4 points, it was the even light distribution. So why does near to intermediate range matter for most patients? Intermediate tasks are often done at arm's length, like I already said, using the laptop. So 80 centimeters is okay for around a person who's 6'8". But certain human factor surveys and OSHA recommended 60 centimeters for comfortable computer work. So why do we have these diffractive zone sizing? Around 4.5 mm is the central diffractive zone that is designed to be less independent on the pupil size or lighting conditions. When it is a smaller zone, we compromise near and intermediate performance in low light or in larger pupil patients. And if it is larger, there's a compromise in the distance vision in mesopic conditions. So one of the most commonly available multifocal or rather trifocal lenses that is available in the market is the PanOptix IOL, that Acrosolve IQ PanOptix that we have all heard of. So this allocates half of the light to distance and splits the rest evenly between the near and intermediate. So there's a fixed light distribution within that 4.5 mm diffractive diameter. So this is how it looks. This is how we can assess for the patient. Again, when we're giving this option of premium IOLs, we do have to counsel for toric as well. So we do need to assess for astigmatic correction for the patient. See whether they require good quality of vision for near intermediate as well as distance. That is without the presbyopic correction. Next, we have certain other multifocal IOLs that are available in the market, such as the Hoya Geometric, which has a smaller diffractive zone of around 3.20 mm. But this works beautifully because outside of this diffractive zone, it also has a refractive element. So it provides good quality of vision, again, for distance intermediate and near. And it also works on light redistribution technology. So you have the Geometric and Geometric Plus as well. So the Geometric provides maximum light distribution for distance and then redistributes it lesser for intermediate and near. Whereas in the Geometric Plus, it provides more light distribution, as you can see here, for the near. So by combining these two for the dominant and non-dominant eyes, we can give a good quality of vision as well for distance intermediate and near. Then we have these EDOF lenses. So what are these EDOF lenses? Extended depth of field or extended depth of focus lenses. Some traditional EDOF technologies are, as you can see in this slide, and there are various new wavefront shaping technologies as well. So desired EDOF is good distance and a good intermediate, right? So first there was the IC8 lenses that worked on aperture sizing. So a smaller aperture was etched into the IOL such that it provided extended depth of focus by pinhole. Pinhole. Next came spherical aberration IOLs. Then we have diffractive EDOF lenses and wavefront shaping IOLs. These are all EDOF lenses. So so what they mean by these EDOF or wavefront shaping IOLs is they provide a slight surface transition where there is a slightly elevated smooth plateau that stretches the wavefront and creates a continuous extended focal range. So this is what they mean by wavefront shaping technology. It stretches the wavefront to give good intermediate. This is just an example. So monofocal IOLs, as you can see the wavefront, it is good for light intensity distribution. There is a good distribution for distance. In diffractive EDOF lenses, there is a good distribution for distance and intermediate. In these wavefront stretch extended focal lenses, continuous extended focal range lenses, there is a pretty good wavefront that is light distribution that's there for distance and intermediate. So out of these modern multifocal IOLs, we are trying to give excellent vision for all distances to the patient with minimal dysphotopsia, with a crystal clear capsule, hydrophobic material, preferably with square edges for PCO prevention, lenses that have good rotational and axial stability. So certain toric IOLs that have proven to have good rotational stability, especially for those that have haptics which are roughened, such that they are mix compatible and easy for handling as well. Like I said, these multifocal IOLs, we have to look into providing our patients with toric multifocal IOLs. So we have to assess for astigmatism in these patients, which is where the topographers come of use. Patients with such a regular bow tie astigmatism are ideal. Patients with irregular astigmatism, it is not preferred to use these type of multifocal IOLs. Stable keratoconus, it can be used if, again, their topography is suitable, even in PMD and even post-keratoplasty, they'll have a lot of aberrations. It's preferable not to use a multifocal, but you can provide toric IOLs for those patients. As you can see here, this is the holiday EKR map. So when we perform this for patients with slightly irregular corneas, if they have this steep, sharp peak, as you can see in the second map, they are more ideal for providing these multifocals rather than in the first one where it's kind of flattened and quite irregular. Next, we also look at aberrations and we measure for angle alpha. So with the eye trace, we can measure angle kappa, angle alpha. Angle kappa is more relevant for refractive surgery, but angle alpha is relevant for these type of premium IOLs. Angle alpha measures the distance between your visual axis and the optical axis. So any bit of decentration will lead to a lot of dysphotopsia and not ideal results. So usually we keep it as less than 0.5 would be ideal for an angle alpha reading when planning these type of lenses. We also look at the total aberrations within the eye. So as you see here, we have the total aberrations. Out of this, what is contributed to by the cornea and what are the total internal aberrations. So from this map, we can actually see that the total aberrations within the eye, majority of it doesn't come from the cornea, it's coming from the internal aberrations. So this is from the lens. Once we correct it and put a lens, the patient will be quite comfortable. So some of the challenges you might face on a daily basis is long eyes. It is difficult to calculate accurately the IOL power in long eyes. They have quite an inaccurate axial length measurement, might have posterior stapholoma or localized ectasia. There's also poor fixation if they have macular disease. Indentation of the cornea while performing A-scan applanation. Usually when planning a premium IOL, it would be better to use optical biometers, especially for axial length measurement and not indentation. Immersion would even work better rather than indentation. Decreased predictability of biometry formulae in axial lengths of more than 27 mm also. um, uh, there are no available lenses less than +6 diopters in the multifocal IOLs. So that is also a hassle. Next, we have challenges within short eyes. So it is difficult for IOL power calculation because of a shallow anterior chamber, less than average corneal diameter, difficulty in calculating effective lens position. Again, there's a lot of fluctuations within the ELP, and even a minor fluctuation within the effective lens position will lead to a lot of residual refraction that pops in. High IOL powers, again, it's difficult for manufacturers to provide this. Again, I don't think it's available more than +13 most of the manufactured IOLs, the premium IOLs. Also, the formula. Yes, for shorter eyes, we do say Q is better, but we have seen for all eyes, short, normal, or long, the Barrett Universal 2 works very well in our hands, and it is also integrated into the IOL Master 700, so it makes it much easier. So yeah, it's very, very important to assess and compare with different formulae as well. So this is just an interesting case example that I thought of sharing with you. The patient had undergone LASIK many years ago, along with a phakic intraocular lens implantation. He was a high myope. So yes, bioptics was used in this patient, and the IOL power calculation was quite tricky because this is post LASIK and with a phakic intraocular lens. So we assessed based on various formulae. So it's sometimes really important to customize the formulae for the IOL. So not only taking one formulae, but applying various formulae and kind of comparing them. So this is how we usually do it in our center. And one more thing to keep in mind, as you can see here, in the left side, LVC is kept as untreated. In post-LASIK patients, it is really important to put that they have undergone LASIK so that we get a more accurate biometry. When it's untreated, you can see the power that it was showing +0 diopters. But once we put in LASIK, it showed +2.5. So we ended up using +3, and patient had a pretty good outcome. This is another case with short eye, 19-year-old male. Yeah, he had right eye uncorrected distance 20 by 1000 in yeah, CDVA was around 20 by 125 and 18 with a refraction of +12. So yes, he was quite a high hyperope. And again, as you can see here, we have compared different IOL formulae, taken the Barrett Universal 2, Q, Haggis, SRKT, everything, and compared the IOL powers. So that is something that is really, really important when you're making your decision. Sorry. Yeah. So in the ending, we saw that this patient had a requirement of around +26 and +27 for his +46 and +47 diopter IOL for these eyes, and it had to be custom made. So that is why it is important. And the axial length was around 17.16 and 17.06. So these kind of patients, it's difficult to promise them these type of multifocal IOLs. So I'd just like to summarize a little bit on this very, very vast topic, that it is important to counsel your patients first and foremost, listen to them, hear them out based on their requirements for spectacle independence or not. It is important for customization of the IOL power, assess amongst different formulae and try and use reliable biometers. Sometimes we cannot give them if they do want spectacle independence and we cannot give them multifocal IOLs or EDOF IOLs, it's better to try maybe for a micro monovision, which has proven to have pretty good outcomes. It's important to also understand the technology that is available in the market. Again, it's very vast. Each company, each manufacturer, each type of premium IOL that's available in the market has its own technology. I've just tried to touch upon a little bit of it today. we have to offer the options to the patient. So it's never a good decision, never a good idea to just make a straightforward decision for the patient. Give them the options and allow them to make that decision. Use whatever technology is available in the market to your advantage. Don't hesitate to mix and match to give them the best outcome. Remember, you are the best counselor for your patients, and it's always better to under promise and over deliver, especially on complicated cases. Thank you.
Thank you, Dr. Sushmitha. I think that was a lovely presentation, and you covered most aspects of it. So before we go to the audience, just one question, because the topic is premium IOL. So do you feel that monofocal is now outdated, or does monofocal still exist? If a patient says, ki, whatever you want to do, you do. So do you put a monofocal or do you put
Yeah,
a trifocal?
I still use a lot of monofocals, and it is very much relevant in this day and age. Like I said, it's important to talk to your patients and listen to their needs, ask them for their occupation, ask them for what is a priority in their life, whether when contrast is important, when that clarity of vision is important. It is always better to go in for monofocals. Also, complicated cases, like I mentioned, when there is pseudo exfoliation with zonular weakness, when they have certain corneal dystrophies, when they have retinal pathologies, when they might require lasers in the futures. All these patients, multifocals are not ideal for. So yes, monofocals do have a place to this date. And also we have a good amount of enhanced monofocals that have also come into our market, which does provide good vision for our patients, even up to intermediate, like iHands does have a good extended depth of focus as well. So yeah, monofocals, enhanced monofocals do have a place. Sorry?
No, I think that was just no, what I mean to say, a patient, uncomplicated case, a patient who doesn't have any pathology, and he gives you the option that whatever you want to put, I have no this. Would you put a multifocal, a trifocal, or would you put a monofocal?
That depends on their needs. So I will ask them, do you need spectacle independence? Do you want to continue wearing spectacles? If they say, yes, madam, I'm okay wearing my glasses after, even cataract surgery, then yeah, I can go ahead with a nice, clean monofocal. They have good quality of vision. I'm not bothering them. Also, price is something that is important. Multifocals and premium IOLs are more expensive. You need to ask their patient how much they're willing to pay, what their insurance covers, what if they come under any schemes, what is covered under that. It's never a good idea to push a patient too much. Ask them what they're comfortable with, and then you can provide that service to them.
Okay. One more thing, I think that is pretty obvious, but a few of the residents have messaged me that what do you mean by micro monovision?
Micromonovision is providing a difference between both the eyes of anywhere from 0.75 to within 1.5. So we try not to go more than a difference of 1 diopter. So this is where for your dominant eye, we give a good distance vision. So we target emetropia. And for your non-dominant eye, we target a little bit of myopia. Usually most people, practitioners prefer like a -1 diopter myopia. So that gives them good for in the non-dominant eye for near. So if they're able to tolerate this, they are very happy. In fact, they very comfortable. Sometimes patients come and be like, I don't need glasses. I'm comfortable. I can see good for distance. I can see good for near. Yes, there is a little bit of neuroadaptation. We do have to counsel the patients for that as well. Even in premium IOLs, even in micromonovision, we need to counsel them regarding neuroadaptation. Tell them that it can take up to 6 months.
Okay. So I think that clears a lot. And so someone who's starting their, who's going for his first premium IOL, maybe a trifocal. So what are the things, can you do this without maybe a aberrometry or a topography? Can you go for premium IOLs? Can you operate without these devices, like you said, eye trace and
I
or
mean, there's nothing like you can't, but keep in mind these patients are paying the cost of premium IOL. And when they pay so much, their expectation is quite high. So that puts a lot of pressure on you as a doctor to provide that as well. So it's good. If your tools are good, it makes your life very easy. If you are planning to start off with your multifocal practice, maybe from monofocals, you can go to advanced monofocals, maybe EDOF as well. For that, you don't really need aberrometry. As long as you have a good, reliable optical biometer, that's pretty good. But if you're planning certain premium multifocal or trifocal IOLs, it is always better to do your topography and as well as aberrometry, because you can find out certain subclinical keratoconus patients, that you might not pick up with just your biometry. So once you see all this, you can counsel the patient properly, and also they won't come to you later on, badgering you and being like, okay, I'm having this glare, this halo, this astigmatism. I've paid for the best of best lenses and my vision is not too good. So just for you to have the best tools and the best, team, basically, it's important to invest in these tools.
Okay. I think that's a good point. One more thing, like you said, under promise and over perform. So a lot of the newer practitioners and the young ophthalmologists, they ask that if they are under promising, sometimes it feels that they are demotivating. Like, so what is the thin line? Because it is very thin line whether the patient gets the message which you are trying to put. So, do you have any tips? I know you may be having some professional counselors, but when you are approaching a patient or when you were in the beginning, how or some tips to the
So even if you're in an institute such as the one I'm in, which has professional counselors, it's always important to counsel your patients, because at the ending of the day, you're the one who's performing the surgery and they'll come back to you. They'll not come back to the counselor and badger them. They'll come to your OPD. So when you are looking at your patients, you're the primary counselor. They will provide the details, but you should ask them questions, and under promising does not mean you are demotivating them. It means you are giving them the available knowledge and your expertise as well. So don't rely on just data, studies which show this, that company people that come and approach you. You will know the results that you have seen with the lenses that you have used. So that is also your expertise. So you have to share that with the patient. Tell them that. So first ask them the questions. I think one of my initial sites was a bunch of questions that you can ask them. Then based off of that, based off of understanding their personality, because that also matters. Certain type A personalities, I would not advise multifocal IOLs. They will not be able to tolerate the drop in contrast or the slight bit of glare and halos at night. But some patients are extremely comfortable with that because they just wanted to have spectacle independence. So you'll get to know them as a person, get to know their personality. And based off of that, you can give your advice. Do not need to give the entire gamut of multifocal IOLs that are there in your arsenal. But you can just tell them, see, in my experience, I feel like this would work for you based off of your needs. So even if you're having two options, say they want some level of spectacle independence, you can give them, ma'am, I'd suggest either EDOF or suggest multifocals, like that. Or you can be like, ma'am, you're not really suitable for multifocals. I'd advise, maybe an enhanced monofocal, like that. So give your advice, don't push the patient, but give them the necessary information.
Okay, okay, that is very good advice. So I think we'll go up to the audience if anyone has any questions. I think Dr. Shushmita is there. She has spared her time. So if anyone wants to ask, can directly take the mic and ask. And this is actually houseful because there are a lot of these people who are waiting, and our license is not able to accommodate them.
Oh.
Yeah, I think Dr. Tejas, are you there?
Uh, yes, Anuj.
Yeah, please go ahead.
So yeah, Dr. Sushmita, I had two major questions. One is that if somebody does not know his own SIA, can he go ahead and start premium IOL practice? And second question would be that if the patient has a small pupil, then while operating, obviously the pupillary expanders might traumatize the sphincters.
Hmm.
So are they good candidate for premium IOLs? These are the two questions which I would like to.
So, your surgical induced astigmatism, you should ideally be aware of it when you're starting up premium IOLs. Um, a lesser surgically induced astigmatism is always better. Again, usually premium IOLs, when you're implanting, you would do phaco and implant these. And if you are doing phaco mixed procedures, surgical induced astigmatism should be around 0.5 diopters. It should not be too significant, 0.5 to 0.25. So that should be okay. Mostly the astigmatism will come from the K readings that you take before the surgery. So we keep a margin of around 0.75, as low as 0.75, in fact, when assessing for toric premium IOLs, just to give them, that good astigmatism correction as well. Now, speaking of pupil expansion devices, just because they have a small pupil does not mean that they're not eligible for multifocal IOLs. Like you already mentioned, using pupil expanders like the Malugan ring stretches the pupil to an extent and causes some trauma. So even if they have a small pupil, say a 3 pupil, and you use one of these expanders, post-operatively, they might come to you with a pupil size of around 4 to 5 because there's some sphincter damage, they do dilate. So that is good enough for these diffractive IOLs. Like I said, diffractive IOLs you get from anywhere from a 4 diffractive zone to even 3.2 diffractive zones. So you just have to keep in mind for these kind of IOLs and then implant.
Okay.
So, regarding this surgical induced astigmatism, do you actually calculate how much, or those calculators which are available, do you actually calculate on them, or it is just you see your post-ops and how they are doing and just get an idea?
You do.
Real world, because
Yeah, in all reality, you can't sit and use those calculators. So if you're taking a real world example, you will know what your patient has, their pre-op astigmatism, and how much they're left with after the surgery, how much you've targeted. So you'll get to know generally based off of, doing your phacos, how much surgical induced astigmatism you actually have. And it
oh,
shouldn't be too much nowadays. I mean, most people use small incisions, 2.8 to like 2.2 to 2.8 incisions, clear corneal incisions that do, and it's not too significant nowadays.
no. Anyone else has any question for Dr. Sushmita? So we have some in the chat. Um, Yeah, this is a very practical question for an ophthalmologist patient. Would you go for a multifocal or a EDOF or a monofocal? And I think this is the time you
Already.
have to overpromise and overperform as well.
So, I haven't actually operated on any ophthalmologists so far in my young career, but how I've usually seen it play is they kind of know what is available in the market. They have done their research and they will come to you with what they want. So it is important to listen to them, uh, take it into consideration. You can do your evaluation, your assessment like you would for any other patient. And the reason they've come to you in particular is because they might have seen your patients and your results, and which is why they've chosen, like, see, I know Dr. Anuj's results, I want to go to him. So they'll come to you and they do want your advice at that point. So hear them out. Maybe they'll have something in their mind. You can tell them based off of your panel of assessments what you feel is best for them, and then take the decision.
I think here professional counselors may
Yeah.
you can put it on. I don't know what they had promised. And dominant eye myopia or non-dominant, I think this is for micromonovision.
Meaning dominant eye you target for distance. In the non-dominant eye, you target myopia so that they have a good near reading.
In a high myope where we are putting a monofocal IOL, should we keep the target refraction myopic and how much?
Yeah, we keep the target as myopic because usually in high myopes, they have a great quality for near rather than the distance. They have adapted to that their entire life. It's better to target myopia, slight myopia of -1 at least. If you're planning EDOFs, multifocals, try and go for an EDOF that has a plus add of say +4 at least. So Synergy has that. You can use that. Again, in high myopes, look at the retina, look if they have any macular scarring, staphylomatesia, all those are important as well.
EDOF in one and mini mono in non-dominant eye.
EDOF in one and mini mono in non-dominant eye.
That is
Like EDOF in the dominant eye, and so you're
mini-
targeting myopia in the non-dominant eye.
yeah.
You could do that. Depends on which type of EDOF. Certain EDOFs with more diffractive rings provided will have a dip in the contrast. So if you feel like patient's going to have that difference between both their eyes, like I said, monofocal provides you really good contrast vision compared to some of the EDOF and multifocal lenses out there. So when you're doing this, you'll have to be a little careful. You can. Usually we put EDOF in both the eyes. Patients are very comfortable with distance intermediate. Sometimes even near they don't require because EDOF, it gives them good vision for their computer. And most people nowadays they use their computers to read and things like that. So it's only for the very fine print, like newspaper readers that require very crisp near as well.
Okay, we have one question. What is acceptable Q value?
On your pentagram, see when you're looking at your when you're looking at your, I'm assuming it's the topography, don't just look at these values, look at the overall topography, look at your curvature maps, look at the anterior elevation, posterior elevation, thickness maps, everything. I mentioned the EKR value as well. All those will be important as well, not just any one value that, index, keratoconus index, Q value, this thing, that thing. So it's important to look at all of these. I'm assuming you're asking for aspheric, non-aspheric,
There's
and
a question and even the angle alpha. So,
angle alpha. Yes. So angle alpha is the angle between your visual axis and your optical axis. So that's pretty much where the IOL sits within the bag. Now, if there is a bit of a decentration from the visual axis of these patients, they'll have a lot of dysphotopsia. The rings are supposed to sit exactly right in order to provide that distribution of light and proper focal points. Now, if that is offset, the whole system, the optical system goes off. That is why we take an angle alpha within usually 0.5. And that's what I showed in the eye trace.
okay. Why regular bow tie is contraindicated for MFIL?
It's not. Regular bow tie is an indication. It's irregular, like iris asymmetry, gross iris asymmetry, irregular astigmatism. Those are the contraindications. Regular bow tie is an indication, sorry.
And, what about young patients, especially male young patients, considering driving and long life ahead?
Male young patients. Yeah, okay. If they are considering night driving and they are quite particular regarding that contrast sensitivity, lack of glare and halos, you can give them EDOF lenses. There are some pretty good EDOF lenses in the market. You can even give them enhanced monofocals, like advanced monofocals or mini monovision. Just do the dominance testing for them, see that they're accepting that.
And I think you have already answered this. Is topography absolutely essential before a toric IOL?
Not toric IOL. Toric IOL, you can use your biometers as well to get the K1, K2 reading. It's for your multifocal torics, so where it is important. Like I said, you're promising a lot when you're planning a multifocal.
And acceptable SD range during IOL calculation. And what is the difference between monofocal and advanced monofocal?
Advanced monofocal gives you a slightly more extended depth of field, like around 1.5 or so, depends on the manufacturer, what they're promising. Again, each one of them say they have their proprietary technology to provide this. Um, but basically, they're stretching the wavefront in order to give a slightly more extended depth of field for you.
Okay, so the next question is already follow-up, and how is it different from EDOF and advanced monofocal, or it is just the a marketing?
No, it's not just the marketing. These are actual results that have been observed in patients. So EDOF, there are different types of EDOF. The technology for each EDOF is different. So, like I mentioned, the IC8, which is the pinhole aperture, was one of the first EDOFs using pinhole for extended depth of field. Then you had diffractive rings EDOFs, just like the multifocal, providing different rings for an extended depth of field. Then we have the wavefront, the X-wave technology, kind of stretching the wavefront, providing a dip or a button type of configuration. Yeah, you have different technologies for different types of EDOFs. I mean, it's there. You have segmental multifocals also. That's one more thing, like the femtis.
Yeah, so another question from one of the residents is, can we do premium IOLs under a block, or it's topical is the way?
I mean, you can do it under a block. That's okay. You can put it if the patient's not cooperating, it's okay. You'd rather have a clean, neat surgery under the block, under a good block. That's okay. That's acceptable.
Yeah, a lot of people feel that topical is yeah, but it is just the surgery remains the same and the patient also gets the same result. It's just that intraop may be a little
It's
different.
like I said, it's based on what you promise. If you're gonna be like injectionless, plateless, this and that, then they might have high expectations. But if you inform them that for you it's better that I give a block, uncooperative patients who are quite anxious, that they're not going to focus on the light, you can always give a nice block and then do your procedure like you would.
Okay, one more question from a resident is, in a complicated surgery, where you have promised a multifocal IOL, do you still go ahead with the multifocal if there is zonular dehiscence, or if you have to convert the phaco to a SICS or a ECC, do you still go, or
Depends on, I think, your skill level as a surgeon and what you are confident in doing. So if you have gross zonular weakness, you know that you're not going to have, a good centered multifocal IOL. Always give them at least the option of good distance vision. Because if it's all decentered, then everything gets compromised. Like I said, the entire optical system goes off. So at least if you have, at least if you're able to give them distance, then that's better. And first and foremost, like I said, counsel these patients that they're not even suitable for these procedures. Gross zonular dehiscence. Just you can tell them that you made a decision as the surgeon, in case you've already promised them multifocal, that so and so happened and you made this decision. Then again, I have seen certain skilled surgeons who managed to pull off multifocal IOL implantations in the tutoric when there is like a PC rent or whatnot, and have really good outcomes because they know how to handle the tissue. Like, say there's some sort of rent that's happened. You've already put the lens in the bag, then what would you do? So that's like some challenging cases. Some people do reverse optic capture. Sorry, I'm not sure what's happening. But yeah, they do reverse optic capture, and then that provides great stability, great centration. Some people do put um, some people do put CTR, CTS, and then put in maybe like an EDOF or something. So this just depends on what you're comfortable with as a surgeon, your skill level. As a beginner, probably don't start off with all these tricks to, better to give them, like I said, under promise and over deliver.
yeah, I think that is only for Dr. Sushmitha, and if you're seeing her post-ops and if you're seeing videos or anywhere or hearing the stories, so don't try. And that is very important that if you're into counseling, then don't maybe under counsel about other IOLs that this is not a good IOL, because if you end up putting a three-piece or maybe a monofocal IOL, then it should not be that you are okay. So somebody, I don't know whether somebody wants to share a whiteboard, but just excuse because
Okay.
that is because of the no sponsorship to clinical peanuts. So we have to bear all this. So does anyone has any other question? Because I think Dr. Sushmitha has patiently answered all our questions.
So
And
this is one more thing to keep in mind. This is a very vast topic. Things are constantly being developed in this space, providing patients with spectacle independence, best quality of vision. Manufacturers are coming out with newer technology for all of this. So it's okay to feel like, you're a little lost. There's a variety. Which one do I put? Just try and keep a track of not only what's in the market, what the manufacturers tell you, but also what other doctors have experienced, with different types of IOLs. And then you'll have an idea of this. So what we've discussed now is just the basics. And I think if we discuss this, we can just keep discussing it for hours on end. So I hope I just covered the important bits at least.
yeah, there's one more question. So is Barrett your formula of choice for, or do you?
Yeah, we generally use Barrett Universal 2 or the Barrett Suite for patients because we've had great outcomes with it. And as I showed you in the case examples, um, it's not just the Barrett Suite that we rely on. Yes, we do the Universal 2, but in certain tricky cases where, the key readings are a little off, maybe a stable keratoconus, we're planning a toric, things like that, we also consider the other formulae. And that's what I mean by customizing the IOL based on formulae. You compare different formulae and what the power is, and then you make a decision. And the more and more you do this, you'll realize which one is more accurate in your hands and in your system. So we have observed, yes, Barrett Universal True is pretty good. We use the 2K TK as well because we do get a lot of post-refractive surgery patients coming to our center, like post-LASIK, post-SMILE, post-phakic IOL, all these things. So we find that has very good refractive outcomes, even post-RK, in fact. So that's a whole other topic, but yeah.
Okay, I think that is a good brief, and I think now everybody can start their premium IELTS from tomorrow. And if